Welcome, 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 welcome. This is Dr. Brony again, and today we are here to review MCCQE1 objective chest pain. Yeah, and that's the main thing about this exam. Number one, are you able to identify the condition? Number two, are you able to make the diagnosis? Number three, based on the information you are given, are you able to, say, is it an emergent situation or is it, what exactly is happening? And then your approach to management. That's all that this whole exam is about, and then you being a specific safe physician. So let's start. Today's approach to chest pain. In fact, one of the most important objectives you need to know, one of the most important objectives you need to know. So we're going to take our time and go through it step by step. As I do, I'm not going to rush anybody. And then we're going to walk through this step by, so that by the time you are done, you are very sure that you can, be able to approach this very well. You realize that the whole essence of the QE1 is for you to, as a doctor, be able to identify these conditions which can easily kill a patient and deal with them. And in Canada, we pay particular attention to chest pain. Chest pain is big. Chest pain is not a joke in Canada at all. So for today's objective, I need you to take extensive notes because it's very, very critical. We're going to also send you the replay, but I need you to take notes because it's very, very critical. So chest pain is a very common clinical presentation with a spectrum of underlying causes, which range from benign to life-threatening. This is what the medical council says. And I'm quoting the medical council, I'm quoting the medical council. This is what they say. That chest pain is a very common clinical presentation with a spectrum of underlying causes, which range from benign to life-threatening causes. Okay, so as soon as you see those words, benign, life-threatening, what should come into your mind is that, look, if I'm presented with a case in the exam about chest pain, I need to be careful so that I don't confuse a life-threatening case for a benign case. Please, doctors, are you following me? And that is what I really, really want you to follow. So my take-home point from that point they made, from that objective, is that chest pain can be benign or life-threatening. If it is benign, sure, we can take our time and assess it. But if it is life-threatening, then we don't want to joke with it. That's basically what I'm going to talk about. So I need someone to read this face case for us. We have a lot to cover. And then those in the course also have a class after this. So please, I need us to really go, a bit fast-paced as well. Yes, I think somebody was volunteering.
A 48-year-old male is brought into the ER with a history of chest pain. You will like to review possible causes. And the list goes to cardiovascular causes, pulmonary causes, gastrointestinal causes, musculoskeletal cause, and then psychiatric cause.
Beautiful. So please, in the comment section, may I know who read this? Dr. Akano? In the comment section, maybe you may want to try some, but the other participants in the comment section, can you type cardiovascular? Then you write some of the causes, pulmonary causes, gastrointestinal, musculoskeletal, psychiatric causes. Can we go? And Dr. Akano, can you try one of them? Can you pick one of the systems and just give me some of the life-threatening causes? Remember that I've also been saying that whenever you're preparing for an exam and they ask for differentials and the rest, make sure that you're listing the life-threatening causes first, all right? So Dr. Akano, can you give me at least maybe one or two life-threatening causes of cardiovascular chest pain, like chest pain as a result of cardiovascular condition? Can you give me something like that, please? Or maybe pulmonary causes. So what I'm trying to say is that...
Should I mention it or type it in the chat box?
Oh, no, you can mention it because you were unmuted.
Yeah, myocardial infarction and pulmonary embolism.
So myocardial infarction, pulmonary embolism, will it be cardiovascular or...
Cardiovascular.
Will you consider it as cardiovascular or pulmonary?
P is pulmonary.
Okay, good. So can you give me one gastrointestinal cause as well?
GERD.
GERD, beautiful. What about one musculoskeletal cause?
Costochondritis.
Costochondritis. What about one psychiatric cause?
Panic attack.
Panic attack. Beautiful. So you see what I want, and then you realize that panic attack will not be life-threatening, but myocardial infarction and pulmonary embolism will be life-threatening, right? So you want to be able to segment these concepts into your mind. I just want to see some of the answers. Panic attack, anxiety, panic attack. That's, yeah. And then cardiovascular acute coronary syndrome, aortic dissection. Beautiful. So if you should get into the crust of the matter, cardiovascular causes, we have ischemic causes like acute coronary syndromes, stable angina pectoris, and then non-ischemic causes like aortic aneurysm, pericarditis, right? So please, while we're also mentioning these conditions, one thing you also want to learn is how do each of these conditions present? How do each of these conditions present? In fact, when we're about to be done with the class today, I'm going to take us through a very quick rapid fire on how to approach these presentations. Okay, so now let's look at the pulmonary causes or mediastinal causes. So pulmonary embolism. So Dr. Kano, that was what I was referring to. So pulmonary embolism or pulmonary infarction, okay? And then pleuritis, for whatever reason, maybe the patient had a chest infection and then now he's developed some pleuritis, pneumothorax, and it can be simple pneumothorax or tension pneumothorax. And it can also be, a lung malignancy like a lung cancer as well. So please learn the cardiovascular causes of chest pain, pulmonary causes of chest pain, and then among all these, learn the ones which can cause life-threatening issues and those which do not cause life-threatening issues. Okay, so the gastrointestinal causes, you have esophageal spasm, you can even have esophagitis, peptic ulcer disease. All right, doctors, I hope I'm not moving too fast. Okay, Mallory-Weiss syndrome, biliary disease, and pancreatitis. They may be in the abdomen, but they can cause presentations which will cause you to think that something bad is happening in the chest, right? And then musculoskeletal causes, you can think about costochondritis, and some people call it Tietz syndrome, okay? And then psychiatry, anxiety disorders, which can even become so bad that the patient can then develop panic attacks. So doctors, are we okay with this? Are we okay with this particular first question? Hello, I want to move on.
Yes.
Can we move on? Beautiful, beautiful, beautiful. Okay, good. So the objective then says that given a patient with chest pain, the candidate will perform an initial assessment, including A, B, C's, to determine the urgency of the presentation and the need for emergent management. So if you have a patient with chest pain, the medical council is expecting you to know, how to perform an initial assessment of the patient and to determine the urgency of the presentation and the need for emergent management.